Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, an interview with Dr. Paul Spiegel, the director of the Center for Humanitarian Health at the Johns Hopkins Bloomberg School of Public Health. From November 24th to December 21st, Dr. Spiegel served in Cairo, Egypt as a strategic advisor to the United Nations Relief and Works Agency for the health response in Gaza. He speaks to Dr. Josh Sharfstein about this experience. Let's listen.
Dr. Paul Spiegel, it is great to see you on this Zoom. Let me just start by asking, where are you right now?
I am currently in a small town called Hopkins in the Netherlands.
And what brings you to the Netherlands?
Well, my wife's family lives here, and I've just returned from a month in Cairo working on the Gaza crisis.
So that's what we're here to talk to you about, that experience. I want to start, though, just by asking you to introduce yourself again to our audience and maybe give them a sense of how you wound up in Cairo working on the Gaza crisis.
Sure. So I'm a Canadian physician epidemiologist, and I've spent the last 30 years or so working in humanitarian emergencies. I started, as many do, working with NGOs like Doctors of the World and Doctors Without Borders. Eventually, I moved on to working with Centers for Disease Control, and then ultimately the UN High Commissioner for Refugees. And since really 1992 was my first experience when I worked with Doctors Without Borders with the Lost Boys of South Sudan in Kenya. And then since then, I've responded to most of the major emergencies that have occurred up until today.
And so you have been all over the world?
For the most part, yes.
Could you give a few examples of where you've responded to crises in the past?
Sure. Well, looking at the last few years, even it was almost 2 years ago. I looked just looked today when I returned from Afghanistan. So when the Taliban took over, and then I went with the World Health Organization. I also went with WHO about a year or so ago, a little bit over, to run their emergency refugee response for Ukraine. I responded with the various NGOs to the Rwandan genocide, Cote d'Ivoire. I'm thinking across the board, many places in Mali, in Ethiopia, many of the major emergencies. And often what I do is I respond to run the beginning of the emergency or to help manage the initial part in putting systems in place while waiting for the other team to come in that will stay for a longer period of time.
And now you also run the Center for Humanitarian Health at the Johns Hopkins Bloomberg School of Public Health.
Yes, I joined Hopkins approximately 7 years ago as a professor of practice, and I direct the center there. And that's been a change, but it's been a very pleasant change where we do a lot of research, education and training, and more evidence-based advocacy. And it's allowed me to use what I saw in the past in terms of practice to try to fill the gaps in terms of particularly evidence to improve humanitarian responses.
So based on your extensive experience and your work at Hopkins, which gives you the opportunity to take time to do some of these deployments, you must not have been entirely surprised when your phone rang this time.
No, and I'm actually quite grateful to Hopkins to allow me to continue to respond, because I think that makes me a better professor and teacher. So no, I was not surprised. And in fact, if I'm not mistaken, my recollection may have been that I was speaking with a colleague who had just contacted me because I had just done a media interview on Gaza. And he said, that was great. Do you want to come? And I said, yes, I'd love to. And I'm not sure if he was even serious at the beginning. And then we continued speaking. And I was very pleased to be able to try to support the crisis in Gaza.
Was there anything different about your decision to go?
I would say, with my background as I'm a Canadian of Jewish heritage, I thought a little bit, firstly, about what happened in terms of the Hamas's attack on October 7th in Israel and the incredible trauma that caused, and the shock and the horror of that situation, and then the hostages that were taken from Israel into Gaza. So I had to think a little bit about that situation. I was also concerned, even though most people won't know my heritage, would that be an issue? But so I gave it a little bit of a thought, but to be honest, not a huge amount, because it doesn't really, for me, make a difference who is affected, their religion or their ethnicity, or even the type of war, but rather if I can support and help civilians in these crises. These are the basics of humanitarian principles, of humanity, neutrality, independence, and impartiality. So while I had to think about it a little bit, I realized very early on that I would be more than happy to be able to respond to this, and frankly, any other humanitarian emergency that can use my support.
Your focus is on saving lives first and foremost.
Yeah, always. And the politics, especially as we all know in the last many years, has become much more toxic. So I think in the past, people wouldn't have even commented or cared. The idea is it's saving lives no matter where they are, or at least helping to save lives. But the situation now, in many, many situations, whether it be migrants, whether it be now, of course, Israel and Hamas, it's very toxic. So you do get much more, many more comments, both positive and negative, in this sort of response than I have in any other response, which didn't surprise me, but wasn't always pleasant.
Dr. Spiegel, you mentioned comments that you've received. Could you be more specific? What kinds of comments are you talking about?
Sure. It was the first time I think I was questioned about, why are you going? Should you be going to this situation? And because of my background, my Jewish background, but also I think people's take on the situation between what was happening in Israel and then Gaza, and that surprised me, because as a humanitarian, that really doesn't come into account. The idea that I should be going, or I would like to go wherever I can to help people affected by conflict. And as I said earlier on, it doesn't make a difference whether it's their religion, their ethnicity. It's truly about being independent and neutral and responding to humanity.
Let's talk about the actual experience that you had. So you're leaving the comments, any questions you had behind, you're taking off and you're heading to Cairo. Is that right? Where you were based?
Yeah, I started my first week actually was in Amman, where I worked with the UN UNRWA, the UN Relief and Works Agency, which is an organization that provides support, education to Palestinian refugees. And so their headquarters is in Amman and then Jerusalem. And just to say very clearly that I'm speaking on my behalf and not on UNRWA's behalf, but I went with them as an advisor in health to be able to aid them in their response to the Gaza crisis.
So 1 week in Amman, what were you doing there?
Yeah. Very similar then after my 3 weeks in Cairo, where the first week in Amman, it was getting briefed by everyone there, as well as people in Gaza, understanding both UNRWA. I mean, like any agency organization, there's a culture, and it was very important for me to meet the people with whom I would be communicating. And then I knew that I would be going to Cairo because much of the response and the coordination is occurring in Egypt because of the Rafah crossing. And so we were based at a small group of us from UNRWA were based at the World Health Organization's EMRO, which is their emergency regional office in Cairo.
And what do you do on a day-to-day basis when you were there?
Yeah. It varied because sadly the situation was changing. But what I did is I worked with the director of health and also of at headquarters, so based in Amman, and then also with the head of health in Gaza, and she happened to be based in Cairo at this point. She had left for completely related reasons before October 7th. And so we worked together to develop systems. So, for example, to initiate what's called an incident management system, to have a very clear prioritization of what needs to be done, when, who is responsible, timelines, and follow-up. The other component was to be working with the UNRWA colleagues, the health colleagues in the field, as well as WHO and others, but specifically UNRWA, who were in Gaza proper. And we would be working with them on everything from particularly diseases of epidemic potential. Systems were already in place. We wanted to improve them and also work with them to plan for potential responses of epidemics because of the situation, of which maybe we'll discuss a bit later. The situation is so poor that it's expected that there will be epidemics, and we all needed to plan accordingly.
So now you've made it to Egypt. You have a firsthand look on what the conditions are in Gaza. What did you see?
What I saw was a horrific situation, something that it's very hard to compare, so I don't want to compare to other crises, but what we saw was a place where there was so much displacement. 85% of the population has been displaced, but there was nowhere safe to go. Certain places where they were told they were safe, but then they were bombed. We saw, I've seen water and sanitation issues, for example, were so severe that people moved into shelters, primarily UNRWA or government shelters, which were schools. There was hardly any toilets available. So, for example, the average in 95 shelters of UNRWA, there was one toilet for 400 people, one shower for over 1,700 people. So normally, the minimum standards, the sphere standards, is one toilet and one shower for 20 people. And the ranges of what we saw were from about one toilet for maybe 50 or 60 people up to no toilets in some situations, because they're in schools where nothing is functioning. Most of these shelters are in these multi-story schools. So water and sanitation was incredibly poor. You had people over 100 people in a schoolroom together. So it was incredibly dense, and there was not enough food. So people were not even sometimes able, at a minimum once a day, but not even once a day. And all they could get were canned goods that were canned beans or anything that was available that either UNRWA was distributing, or that was in the stores, which were eventually completely depleted.
And the number of people exposed to these kind of conditions?
Extraordinary. So out of the 2.2 million people in Gaza, 85% have been displaced. And so we're talking well over, I believe it's 1.7 million people. In UNRWA shelters themselves, there's now over 1.4 million people crammed into these 95 schools. And so UNRWA was, and others were providing consultations, but the numbers of consultations that they were providing was far higher than they had done previously in the war. And even the numbers of consultations per healthcare provider is so high, well over 100 to 150 per day, that you can imagine they're spending maybe 1 or 2 minutes per person, and there isn't even enough supplies of medicines, because they're not allowed, or the humanitarian community is not allowed to provide the numbers of medicines, food, and water that's needed right now. It's not getting across from Egypt.
So when you're talking about consultations, that's another way of saying medical visits, right?
Yes.
That people have health problems, and the doctors may be able to only spend 1 or 2 minutes per person and may not even have the medicines to support them.
Correct. And then there's that. And then if you wish to, if a doctor wants to refer, which is often the case because this is primary healthcare mostly, most of the hospitals now, or many have been attacked, and therefore they're hardly functioning. Right now, only a third are partially functioning in Gaza. And so anything really, really serious is a problem because number one is access. Will they be able to get to a hospital without being bombed? And then number two is we know that there's no space in these hospitals. They're lacking anesthesia, so they're only doing very, very rudimentary procedures.
Can you talk to me for a moment about the risks of infectious disease in the conditions that you've been describing?
Yes. So UNRWA was collecting in these 95 shelters of over 1.4 million people now, 14 diseases of epidemic potential. Every day they were reporting. The largest by far are acute respiratory tract infections and diarrheal cases. We're seeing, we compared to the similar month the year before. It's not an exact comparison, but we were seeing up to 60 to 100 times more cases than were reported previously. That's number one. Number two is there were cases reported of hepatitis, and we were still investigating that. One of the problems is that there's insufficient labs that are functioning right now, and so it's very difficult. It's mostly going to be syndromic. There also is bloody diarrhea, and so we're following each shelter daily, waiting because we know it's an inevitability that a large-scale outbreak will occur. It's rather which one. And then the really, really hard part that I haven't had to deal with in the same way in the past is how do you respond, particularly to a waterborne disease, when there is insufficient water and there's insufficient hygiene, and you can't bring in more water because it's not allowed to be able to brought in. And as an example, the amount of potable water that they are drinking, so the drinking water was 1.8 liters per person per day. Survival is at least 3 to 4 liters per day just for potable water, and overall, it's recommended in the Sphere standards that it's a minimum of 15 liters per person per day for drinking water and showering. There is nowhere close to that amount of water, so it's an odd situation, a very scary situation where you know something is coming, you think you have the systems in to be able to document and make alerts, but you likely will not have the proper ability to be able to respond in an effective manner.
It's frankly hard for me to even wrap my head around the conditions that you're describing. One question I have is about special populations of individuals who, almost by definition need medical attention, like people who are pregnant. What's going on?
For the most part, regular antenatal care and postnatal care are not occurring at this point. What is happening if in these shelters, which is the first line of medical consultations, if there's pregnant women or women who've just had babies or neonates are sick, they're seen there. But one of the biggest concerns remains pregnant women and where are they actually delivering. Amazingly, despite many of the hospitals not functioning, there still are some parts of hospitals and some maternity wards that are functioning there. And with the limited information we have, because it's very hard to be able to follow people around beyond the medical consultations that are given, we believe, or at least we are told, that most women are still giving birth at hospitals. Out of the over 1 million people at UNRWA shelters, only 2 have actually given birth in the shelters. Everyone else apparently has made it to hospitals to give birth. But we truly, this is very sad, we don't know the outcomes. So how many people have died in childbirth? We don't know how many pregnant women are actually never got to give birth because they're under the rubble. We don't know at this point.
Would it be fair to say that the risk to the population from some of these conditions may even exceed the risk from the bombings themselves?
There's no question that eventually that will happen. Right now, there are some unique aspects to this situation. What we saw. So number one is that in most situations, there's this release valve where people are able to cross into an area that is secure. Maybe it's another country, maybe it's another state within a country. There is no place where people can go that is secure. So that's extraordinarily troubling. Secondly, though, the amount of bombing and the magnitude in such a short period of time may be unprecedented. And that is what's causing currently, now there are over 20,000 deaths and around 50,000 injured. And that proportion is extremely high in terms of the numbers of deaths. But in all situations, in the longer term, and we will see this here, more people will die from indirect causes, meaning disease and complications of wounds, than they will from actually the bombing.
I want to ask you about the experience of the health professionals who are trying to support the population in Gaza during this period. I imagine working for the UN, that is a concern too.
Working with UN workers, and in particular the NGO workers, most are Gazans. Most are living there already pre-October 7th, because very few can get in. And we've seen this in other situations, but this was extreme, probably because we were speaking with them every day and, seeing and hearing seeing and hearing the bombings of what is occurring. So these people are healthcare professionals. At the same time, they are being affected in the same way as all other people in Gaza. So they're being displaced. They're going from one place to another. They have to queue up and get food and water just like everyone else. And so it was an insight into their lives to show not just what was happening from a health professional point of view, but also seeing what was happening to everyday Gazans, because that is what they were going through as well. And it added a certain amount of anguish that isn't always the case in other situations when you're a little bit removed. It felt this time like because we were speaking to them every day and because we could hear the anguish in their voices of what they were going through, it made it very, very difficult. And it also, we had to be careful of what we could ask of them in terms of interventions, in terms of data, because they were suffering so much themselves.
I know you've had so much experience in these humanitarian responses. Has this experience of talking to people working in these shelters given you any new insights or thoughts about the nature of humanitarian work?
Yes. Frankly, I'm still processing some of it, but what we have been seeing, and not just in this war, but in over the last decade or so, is a shrinking of what we call humanitarian space, meaning the ability of humanitarians to actually work and respond. In Gaza, it's nearly non-existent. It's extremely hard to be able to work in this situation with the constant bombing and places that are declared safe and then are bombed. In this situation as well, and this is just continuing, but it's extreme in this situation, is the attacks on healthcare. The numbers of attacks on hospitals has been incredibly high, and it has negatively affected the ability of the health system to respond. And then it also makes me think a lot about what will be in the future, as I believe this will not be the only situation like this. And how do we deal with risks and our abilities, our obligations to be able to help people, healthcare workers who are responding, and what do they do when they say, I want to leave, I want to be able to get out for my family, which of course they have every opportunity to do. How do we help them in terms of medical evacuation when in this insecurity? So there's bringing up a lot of questions, ethical questions, that we have had to deal with in the past, but not to this degree and not to this magnitude.
So, Dr. Spiegel, we're talking on December 22nd. Your last day was yesterday working in this project. I don't know exactly when this interview is going to air, but one of the advantages of talking to you just so fresh after this experience is that I can ask you what it was like for you to be in this experience. How did it affect you?
I think every conflict or crisis that I respond to affects me differently, some more than others. Just like I think for those that are doctors, you try to be as objective as you can. And we are objective, but sometimes one patient for some reason or another affects you differently than another. I would say that's often the cases in these sort of crises. And so this one, as I said, I'm still processing, I think both because of my background, because of various, as I said, comments and others that are being received by various people, when the goal for me is so clear and obvious and uncontroversial. You'll go help anyone, anywhere who needs support. When in a humanitarian situation, every time I do this, it makes me a better human being and a better professional. But I think this time was one of those times where you have a patient and you say, oh, that affected me in a different way. And I think this affected me in a different way, looking at the suffering of the Gazans and seeing it firsthand by speaking with them every day, both on a professional and a personal level.
Paul Spiegel, thank you for joining me on Public Health on Call so soon after leaving the Middle East. Thank you also for your long commitment to humanitarian health. May your efforts never be needed again. I look forward to seeing you in Baltimore soon.
Thank you, Josh. Much appreciated.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.